Well, thank you. It's a pleasure to be here. So today I'll be talking about PIK3CA. I don't know if this is important, just that I received funding through the intramural program at the NHGRI. And today I'll be talking about off-label use of a drug called sirolimus and briefly mentioning one that's an investigational new drug called Arcuol. So in my talk today, I'd like to describe what we mean by the term segmental overgrowth or mosaic disorders and the underlying cause, which is somatic mosaicism. And then I'll describe the group of disorders which we call PIK3CA related overgrowth spectrum, and I'll call it PROS from now on just because it's less of a mouthful there, and how Klippel-Trenaunay syndrome fits into this condition. The role of the PI3K, AKT, mTOR gene pathway, and then I'll finish up by describing some of the results of our recently completed drug trial for these groups of disorders. So when we describe a mosaic overgrowth disorder, what we're saying is that there's overgrowth that affects a particular body part or a region of a body. And this overgrowth can be mosaic or patchy, involving different tissue types, including bone, skin, muscle, and fat. It's often accompanied by overlying skin abnormalities, which may be pigmentary with dark pigmentation or light pigmentation, as well as vascular malformations, which I and others will describe in more detail. It's caused by what we call a mosaic gene variant. And on your right, I guess, you'll see that there is a picture of how this occurs. So usually gene mutations or changes occur in the germline, in the zygote after the egg and the sperm join. But these types of mutations occur after the egg and sperm join, and it occurs in selected cells within the body. So there are two different, distinctly different genetic mutations within different parts of the body or different tissues. So most of the cells will be normal, but then other cells will have a particular gene variant. And this results in, as you see the individual below, these red areas which designate the areas that are affected by the gene not functioning correctly. So the disorder that I'm going to be describing today has significant clinical heterogeneity or variability. And I think this slide encapsulates the difficulty that we have in terms of understanding the disorder itself, clinical characteristics, natural history, complications of this condition. These two individuals have the same gene variant, and one designation for this, one of the most common variants in this gene is called H1047R. In the figure on the left, we see an infant who has primarily enlargement of a single digit, what we call macrodactyly. And the rest of this person's body is unaffected. While on the right, we see an individual who has multiple tissues involved with this disease, including bone, underlying fatty tissue, and has primarily fibrofatty overgrowth in one leg and overgrowth of muscle in the other, has regional, what we call regional underdevelopment of fat in the upper body, fatty tumors externally on the abdomen and intrinsically, and then vascular malformations that in this person primarily involve the spinal canal. And she has had multiple complications as a result of these findings. This is a collage of other individuals who also have this somatic mutation or mosaic mutation. They're also the first 5 patients that we treated on our sirolimus trial that I'll discuss in a little bit. The child on the top, a 6-year-old girl, has findings of muscular hemihyperplasia, and she has fatty tumors involving her trunk. She has the characteristic widening of her foot with splayed toes. The 14-year-old boy shown here has what is termed facial infiltrating lipomatosis with enlargement of one side of his face. He has typical skin findings that we call an epidermal nevus, which is sort of a brownish skin lesion that's shown in him. The picture on the other side of the slide, as well as this 47-year-old woman who has it also on her cheek. He has hemihyperplasia that's contralateral, involving one side of his upper body and his leg, as well as lymphovascular lesions. The other individuals, you can see some of the vascular abnormalities that occur with a port wine stain or capillary malformation, and continued progressive overgrowth in these other children. This slide also demonstrates the significant complications that can occur in terms of multiple sequential surgeries. 50% of our patient population had amputations and others had debulking surgeries. And 80% of these were serial. They just weren't one-time surgeries because the growth continues in those regions that are still remaining. These individuals also have complications of bleeding, ulceration, and infection, especially those that have lymphovascular malformations. And there is a risk for blood clots and pulmonary embolus from blood clots, especially in those that have involvement of lesions in the chest or the thorax. Other findings that we've identified and other groups have identified can include, interestingly, developmental malformations. Namely, the medical term is polydactyly. You can see it in the photo on the top, but that's extra toes. They also can have extra fingers, but it seems like the lower is more commonly affected. They can have webbing between the toes or syndactyly. We also have seen kidney and urinary abnormalities that it can include a missing kidney or fluid in the kidney or hydronephrosis. In addition, there are several reports in the literature of individuals who have Wilms tumor, a type of malignant tumor, and a premalignant tumor called nephroblastoma. We did a large series with several other centers of 247 patients with this diagnosis, and only 1.6% of those individuals developed this type of tumor. But you can see how it makes it difficult to know how to manage individuals should we provide surveillance for these types of tumors, because a Wilms tumor is a highly treatable tumor if it's identified early on. We've also seen other types of growths, including spinal neurofibromas, which are typical of another condition called neurofibromatosis type 1. This individual did not have evidence of gene mutations that cause that disorder. Vascular malformations, as we discussed, and some of the associated complications that can go along with that, including what's called thrombosis or blood clots, and superficial blood clots, thrombophlebitis. So this is a Venn diagram that illustrates the distinct yet overlapping phenotypes that we see, or clinical pictures that we see with people who have these mosaic mutations in PIK3CA. And I'm sure this will change. This was developed, as I'll talk about, in an NIH workshop that we did a few years ago. But it shows that they're distinguished in a way by their tissue specificity, or there are people who have isolated muscular hemihypertrophy or enlarged finger toe macrodactyly, or ILM stands for isolated lymphatic malformation, as well as isolated skin findings, that SK and BLK are keratoses. But then there are other individuals who have more pleiotropic or multiple tissue involvement. You probably recognize the term CLOVES, that congenital lipomatosis, overgrowth, vascular abnormalities, epidermal nevus, skeletal and spinal defects is what that stands for. And these individuals may be considered more severe because they have more tissues involved. And there are individuals who have primarily central nervous system involvement with neuronal migration defects like dysplastic or hemimegalencephaly and capillary malformation. And I put Klippel-Trenaunay syndrome in here because As you probably know, there are individuals who have this, and they have been identified to have somatic mutations in this gene. So the PI3K-AKT gene signaling pathway is a very important pathway that's expressed ubiquitously in all tissues and plays a major role in cellular growth, proliferation, metabolism, and angiogenesis, which is the development of the vascular structures. And it's highly simplified here because this pathway has many more components and interacts with many other gene pathways. Some you might recognize, MAPK, RASopathies. And this is important to know, especially in terms of understanding why these conditions that we thought were separate entities have such overlapping clinical findings. And I've highlighted the PIK3CA-related overgrowth spectrum, which we're talking about today, and then another related condition we study in our group called Proteus syndrome. And both of these are due to a gain of function or activating mutations that put this pathway in overdrive and cause more overgrowth. But there are other genes that act as inhibitory factors, like this P10 and the TSC, or tuberous sclerosis complex. So, as I mentioned, in 2013, we held an NIH workshop with researchers studying these groups of disorders that included Harvard University, UT Southwestern, Cambridge University, and the University of Washington. And we felt it was important because these disorders are so different or heterogeneous, and there was a lot of confusion in terms of the nomenclature or designation of these conditions. It would be important to develop clinical diagnostic criteria, which we anticipate will change over time as we learn more. But we found in all of our patients that most individuals have onset at birth or in early childhood, and their overgrowth fits with a somatic mutation of other conditions that have those types of gene changes, in that they're sporadic, which means that usually it's one individual that has the condition in the family. It's not usually, very rarely inherited, and it has a patchy, irregular presentation. And then we noted that, as I've described a little bit earlier, that it could be presenting as a spectrum with 2 or more features, and you can see those there, or isolated. And the key ones are the overgrowth of any tissue type, any combination, different types of vascular malformations that are capillary, venous, arteriovenous, or lymphatic, and then this skin lesion I showed you, the epidermal nevus. So I wanted to highlight the vascular malformations because this is the major component of these groups of conditions, and I'm talking to individuals who've been identified to have Klippel-Trenaunay, so it's very pertinent because this is one of the key features of this condition. So this is from your website, actually, the photo on the top of a little child's hand with a venous malformation, and then the hand, arm, and legs of this other girl, or a 21-year-old girl that I saw at the NIH, who was said to have Klippel-Trenaunay syndrome, and she's in the process of having genetic testing with her group right now. But you can see she has venous malformations and lymphatic involvement with blebs or vesicles on her leg, and you can see that she's had significant complications and has had to have amputation of one of her fingers. And then I'm showing the boy that I described earlier with his lymphovascular malformations. As you know, the International Society for Vascular Association Anomalies, has developed a classification schema, and this is from 2018, and it includes what are the types of vascular malformations plus whatever other anomaly is present, and what we know to date, so 2018. So you can see that Klippel-Trenaunay is on the top of that list, and they've listed PIK3CA as a causative mutation, but it's important to know that not all individuals who seem to fit into Klippel-Trenaunay syndrome have this mutation. So there's still a lot that we need to learn about this condition, both in terms of characterizing individuals as well as after that, identifying if there is some type of other genetic mutation. And then on the right, I kind of put the conditions to date that have been included that are caused by this particular mutation. And there are so many different conditions with different acronyms that you can see. CLOVES I've described, but there's CLAPO and FAVA, but they all have overlapping features that I've mentioned earlier. So I thought it would be interesting to look at the medical literature about Klippel-Trenaunay syndrome, and this is from a publication in 2008 by Oduber, and I thought it was nicely illustrates some of the key findings that were used in the initial description in the early 1900s or 1900. So this is a girl that has hemihyperplasia or enlargement of one of her legs, and capillary malformation on her leg with lymphatic vesicles. And on the other side, we see an MRI of her upper leg or femur. The top part is her normal leg, and it does a cross-section in a diagram of what's in there, and it's the skin. And the red is arteries, blues are veins, yellow is the lymph vessels, and then the interstitial or connective tissue. Below we see her leg that's affected and how there's expansion of almost all these compartments, but what's striking is that she has proliferation of her venous structures, her lymphatic vessels are increased, the interstitial tissue is increased, and she has fat infiltration of her muscle, those little yellow blobs in the picture. So I thought this was interesting that Oduber put together a proposed definition, just like we've done with this clinical diagnostic criteria. And you might ask, why do this? Well, it's so important because it helps us develop a homogeneous group of patients that have hopefully the same thing, and then that allows us to understand how does this disease act or progress or not, and what is the underlying cause for that, and potentially what could be additional treatments that could be applied. So you can see that the two major features that they propose be involved are these congenital vascular malformations, the ones capillary venous AVMs, or lymphatic and disturbed growth of bone and soft tissue. And I didn't mention it, I hope you saw it in that picture. We talk about overgrowth, but there are individuals who have undergrowth as well. And then they can have these other findings, they say, including the extra fingers and toes. And you can see, I hope you see that this is very similar, even though it predates ours, to what our clinical diagnostic criteria for PROS is. So it sort of highlights what I said in the beginning, that Klippel-Trenaunay syndrome likely fits into this whole spectrum of disorders that are caused by this mutation. So we believe that, and I'm sure many others too, as we'll hear in Dr. Cannell's presentation, that primary treatment is the way to go for these diseases. They have significant morbidity, risk of medical complications, hospitalization, surgeries, and even death if you have thrombosis. Progressive course, no curative symptomatic therapies, and with the identification of a molecular etiology, it makes them great candidates for inhibitory therapy. And we have a lot of lessons that we can borrow from our oncology colleagues that are treating these disorders for cancer. The dysregulation of this particular pathway, these genes, has been well known in oncology to cause different types of cancers, and so there's been a push to develop drugs that inhibit the action of these genes. So, but we wanted to develop a unique approach. Usually for cancer therapy, it's fairly toxic, that people get very high doses, they can have very significant side effects, but it's acceptable because you're trying to treat a cancer that could cause death. But we wanted long-term tolerability with a low toxicity profile, and so we felt that a low dose may hopefully address that. So we recently completed 2 trials, as I mentioned earlier. The one I'll talk about is the non-randomized open-label pilot study. We also completed a trial for Proteus syndrome, which I described briefly, with a phase 1 dose-finding trial. And we sort of stuck in some methodology to look at, is it effective or not? And we used a drug called ARQ-092, which is an AKT inhibitor. And I'm going to show you that. This is a more complicated diagram of that same pathway I showed you, but it sort of emphasizes where we might inhibit this pathway. So there are drugs that are developed for other purposes that can act as PI3K inhibitors. Sometimes you can use 2 different drugs that pinpoint different areas of the pathway. AKT inhibitors, as in the case of Proteus syndrome, and some, as Dr. Adams' group is looking at this drug for this group of disorders as well, and then mTOR inhibitors that we used. And sirolimus is well known. It's has approved use. It's used to immunosuppress patients who have just received a kidney transplant. So there's a lot of data available on its known side effects, that it's relatively safe in children. So we thought that was a good reason to try this drug. It also is being used sort of widely by the medical community, but there have just been anecdotal reports. And we really don't know if this drug is going to be effective for PROS or if it's safe, because there haven't been controlled trials in the past that have addressed these questions. So our study objectives were to, figure out, does sirolimus really reduce overgrowth in this condition? And we developed what we use and talk about in clinical trials are outcome measures. They're tools that help us objectively determine if the drug is working or not. And so we applied several to see if they would be effective in looking at this question. Photography, quantitative or volumetric MRI scan, DEXA scan for whole body composition, and then a tape measure, so measuring the parts that are bigger or smaller. And then a secondary goal that we had was to determine if it improves function. We really wanted patient-reported outcomes, so we used several different types of validated measures for that purpose, and then objective evaluations with range of motion. So this is our sort of schema for this phase 2 pilot study, and shows that we basically had a period, a run-in period, or an observational period where we didn't treat with any drug, and we did all the tests to look at growth with DEXA, MRI, clinical examination, and quality of life measures. And then we treated for 6 months with sirolimus and repeated those measures and we compared this treatment period to the untreated period. We also did tests to monitor the levels of sirolimus, because you need to do that to make sure it's in the right range to be, and so we targeted this low dose, and I put the exact dose that we were targeting because it's about to emphasize that it was about 4 to 10 times less than the approved use dose for immunosuppression. So our study design was developed by a consortium that we have been involved with, one from University of Cambridge in the UK and University of Dijon in France. And we had parallel study procedures, dosing and scheduling, but we had independent regulatory oversight because they're so different in different parts of the world. It would be difficult to try to make it uniform in that way. And we had 39 patients that we enrolled and treated. 9 ended up being withdrawn or discontinued, and I'll describe why. 23, when we use these outcome measures, only 23 we were able to use our outcome measures to judge whether the drug was working, but we did the safety and tolerability data in everyone. And as I mentioned, there were 39 patients. I threw in the prior diagnoses. We know they have a PIK3CA somatic mutation, but you can see it included KTS, Klippel-Trenaunay, cloves, fibroadipose hyperplasia, and even proteus syndrome. And all the groups had similar age ranges, 3 to 48 years of age, similar gender distribution, and types and distribution of overgrowth. And the overgrowth most commonly occurred in the legs or in the trunk and limbs, and vascular malformations occurred in about 60% of patients. So I thought this was sort of a pretty picture to throw in to visualize what the DEXA scan looks like when we get output from that. But this is our patient 3, the 14-year-old boy that I showed you. And the yellow is fat, the red is lean tissue. And it's the baseline you see here in June, the prior to starting treatment, just prior, then 3 months and 6 months. We put in at NIH, we added in a 3-month time point. It's hard to tell if there's difference here, but the nice part about the DEXA is it tries to quantitate the amount of lean fat tissue so that we get a number that's generated. And this is just an example. This boy had involvement of both legs, with the left affected more than the right, and you can see that there was a slight reduction in fat volume mass. It was about 1.8 times greater difference in one leg and 2 times greater change in the other leg. I'm not going to show you all the data from our trial, but the sort of bottom line is that when we looked at percent tissue volume change, and this is looking at the treatment period compared to the pre-treatment period, we saw that there was volume reduction for the tissues that had the overgrowth or were affected with the abnormalities. And the affected is blue, the blue rectangles, and the unaffected is red. And it showed that there was a reduction, but not in the unaffected tissue. And the reduction was statistically significant, but it was small. It was like negative or 7.2% reduction. But it's good news that the unaffected tissue was not affected, because we want, if this were a treatment in a young person, you want the normal cells to continue to grow and not be inhibited. I am only going to show you this because I think it's interesting to look at. Was there a difference based on what we knew about the phenotype to sirolimus therapy? And these numbers, the p-values, are sort of statistical tests to look at significance, based on the data. And we saw a reduction in every patient, but it's a small number. They were kind of evenly distributed. It's a small number, remember 39. But 23 that were evaluated, so about 6 patients per each group. But it was trending towards significance primarily in the phenotype, or the condition that was a fibroadipose overgrowth, which was interesting. It may tell us something about how sirolimus works, actually, which is a whole other new question. I just am putting in our quality of life assessments. I won't go into detail, but we wanted to look at, does it affect pain, perception, intensity, or quality of life measures looking at adaptive, emotional functioning, medical, physical status, and cognitive functioning, as well as physical functioning. The adverse events occurred pretty frequently, which was surprising to us because we used a low dose, much lower than is reported for the approved use. So 79% of patients had adverse events, but it's important to know that it was felt that 52% were unrelated to the sirolimus. As you know, and you can tell from my description, these patients have a lot of complications, even when they're not on a drug. So sometimes you have to sort out whether it's due to that. The rate that discontinued was surprising. 7 or 18% of the patients had to be discontinued, and this was because of neutropenia, or very low white blood cell counts, a hypersensitivity reaction to the drug, as well as, just lost my train of thought. The other cause was, interstitial pneumonitis, sorry, couldn't remember the last one. And that's like an inflammatory pneumonia problem. So in summary, we thought this trial was useful because it validated some objective outcome measures that are important to have in a controlled trial for the future, and it informed us, at least in the design of a future trial. And sirolimus did lead to some statistically significant mild reduction of tissue volume, but the adverse events weren't insignificant. So future directions, we'll hear about some of those, are thinking about not only which drug to use, or if there should be multiple drugs used at these different points in the pathway that I've shown before, but also what are the best outcome measures to judge whether these treatments are effective, because as you see, there's a wide range of presentation. One person may just have overgrowth and vascular malformations of a limb, while another person primarily has brain involvement. So how do we choose which outcome measure is most effective? And then also thinking about developing trials that will help us answer the question of whether a drug is truly effective. And typically, and I know Dr. Adams will talk about this more, and Dr. Cano, but thinking about, we often need a control arm of a trial or a placebo to judge whether this is actually an effective therapy and to understand sort of the natural history of the condition. So with that, I'd like to thank our patients and families, as well as you, for listening, and many collaborators that have been involved in these studies. From the NIH, our lead person is Dr. Sicker, and then at the University of Cambridge and University of Dijon. So thank you, appreciate you listening.